What do you think about this year's conference?
This right
so
there,
far?
right?
Yes.
Well,
We
I'm
got
sorry
it.
the discussion. I'm sorry the discussion is not that lively, and I think maybe we're on a next stage. Now we are much more in doubt, and,
Yes.
and most of us are doing this, and,
Yes.
and we don't really want to know that we do it. And we are a little bit, we don't know what we do in the first place. And last year and the year before that, we were very scared.
Yes.
We asked all the questions. Now we are in the period of sending patients and doing it for the first time, and probably we don't even know if we are successful. I mean, I had 3 patients sent to Volker, and they were all 3 extremely successful. One got pregnant, afterwards got the baby, natural delivery, and the 2 others are doing more than fine. So I'm not sending enough patients, for sure. I should send more patients. And then I get in doubt again, because then I overtreat, and I have probably mistreat here and there, miss a cigarette or 2, and then get frustrated, and then, yeah, I think we're getting started.
The long-term data is pending, no doubt. What do we do in the meantime? Nothing? United we stand, and hopefully he'll stand with us sometime. Thank you.
Answer your question? No, I don't have a better solution. Outside this room, there's a different world. And there's a reason why I've rarely, if not never seen, a treatment effect as large as this one here. If you widen the indication and don't have a specific cohort where it works, you usually burn the technology. Let's say whoever first author will then review that. The others will just nod to it, then it goes out. It was written by a sponsor, and the spin is quite clear. So I would be very careful to define this as a standard of care for the time being. In your own interest, by the way, because it might happen that otherwise the society will lash back on you and this will be gone before it's on the market, or only a couple of years. Yes. One more time, I don't have the perfect solution, okay? If I had, we wouldn't be sitting here, okay? And I would be careful, because maybe this patient you just described is the ideal candidate who profits from the procedure. But if you widen your indication, and this is usually what happens with new technology, then this patient will not receive it any longer, because it's not going to be on the market in 5 years from now.
There's so many confounding pain generators. You think, as I showed before, that you solve the SI problem. Next thing you know, you have a tear in your disc at L3-4. The patient has buttock pain. They think it's the same pain. I certainly believe we do have to heed the warning of not falling into the trap of a new technology, defining how we treat this problem. We got to just stick to the basics and make sure we're doing this the best way.
That's the question. What is the most ideal candidate to start out with?
Because I think the variability is the huge problem, and how do we make this reproducible, which points to the fact it's not the device, it's the process.
But on the other hand, there got to be rules for that, and as long as I don't know that these rules are kept, I'm skeptical, that's all.
And the caveat to that is the real breakdown is at the editorial level where they allow these things. And I think that if we're going to point a finger, that's where it needs to be pointed.
We know that industry-sponsored studies, as Dr. Freeman had mentioned, are typically higher quality. They're more likely to be randomized. There's no transparency in that process. So we would just ask that the academic elite perhaps held themselves to the same standard as they hold industry.
That's the beauty of having a sham. Okay. Well, we agree on the fact that it's not a standard of care?
Yeah.
Okay, well then, done deal.
And much more than this, I feel guilty, terrible at the far end of my mixed career that I did not take any interest at all in the SI joint. Okay. So basically, I am a fusion refuser. Although I am not sure, after having seen your images, that fusion is a bad thing for that joint. The nerves here are irregular. There is no pattern what I have seen at all. You are the experts. It says expert group. I should ask the questions here.
Just one question. The nerves are in totally different positions.
But the position where you can't say, I can go through with my screw here, because there is no...
Yeah, that's what I'm saying.
No,
so there's no rule.
It's complete chaos.
Pain is an unpleasant sensory emotional experience associated with actual potential tissue damage or described in terms of such damage. And chronic pain is pain that lasts longer than 3 months. And of course, when you do the lateral approach, these are your enemies. Because if you put the implant too anterior, you can damage these nerves. And you have variation in the sacral morphology, and it can have implication for how you do this.
And is there something in the shape of the SI joint that might predict a painful joint from a non-painful joint? We know that there's lots of nerves in this area. We know that there's ligaments that stabilize the joint. But what can we learn from the shape? This is a shape that we might all recognize, right? Everybody knows Mickey Mouse. So sometimes I feel like Mickey Mouse when I don't know what I'm doing. We're looking at the three-dimensional models. We did not input the fourth dimension of bone density as of yet, but it's a logical next step, absolutely.
I think we are not using our manual skills. Patients, tons of patients have never been undressed in the office of a surgeon. Guess what? In many countries now, we are treating radiologists as human persons. I mean, that's amazing. Besides, the age of the spine was thought 30, 40 years. We are getting far too old.
The radiostereometric analysis has also been used to study manipulation. Does this alter the position of the sacral joint? And many manual therapists claim that their good clinical results are consequences of reduction of the subluxation. Although the movement is small, there is some movement that actually can cause pain.
You can also allocate geometric figures to those ligaments, and the reason why I keep emphasizing and keep repeating this is the so-called doctrine of Pauwels. We found age-dependent variations. The iliolumbar ligament and also the cranial parts of the interosseous ligaments appeared to become thicker the older our cadavers that we investigated got. And this is quite interesting because this thickening of the ligaments was somehow related to a decrease in bone structure and also to a change of the rotation of the sacrum that we found in the static environment. And you can actually appreciate how the load distribution is taking place, and that's the horizontal instabilization that you can find here. Actually, that would be a very good thing to look at age-related degeneration, to look at maybe indirect form changes within the sacrum, and then to make an estimation. It will still be an estimation on how that influences load distribution and also consecutive instability or pain generation. There is one short answer to this. We just don't know.
Her CT scan was absolutely normal, not even vacuum. And her story was that she was broadsided in a car crash 5 years before and had terrible pain. And because everything was normal, nobody was doing anything. And one of the doctors who was in the room gets up and he walks out and he murmurs to the people sitting at the reception desk, "It's criminal," and he just runs out the door. So where are you in your spectrum of caregivers? Well, most of us are kind of in the middle here, but there's a lot of stuff on either side. And another point I would like to make at this meeting is the sacroiliac joint is not the spine. So, is there an imaging sign which tells us pain? No, there's no test that's 100%. So here we are, locked, but there's a way out. Examine the patient.
Taking some heat, but now I look around and I see hungry eyes. Before they were angry eyes, just as you represented. And one of the key parts of this is recognizing, if I don't overemphasize that I'm not doing my job, look at it, they point to it, you manipulate it, and you got your diagnosis. You're not confused if it's the thumb or the finger or the IP or the PIP joint. But I will talk about what you need to consider with these patients. And like we know, it's heavily innervated anterior and posteriorly. One of the things we've got to make sure we don't want to give is get eaten alive. And that's when you make the wrong diagnosis and you treat an SI problem when it's a lumbar problem.
About 20 years ago, Dr. Murakami met a middle-aged female patient with severe buttock pain in a small post town. Even though he did not expect it to be successful at all, his SIJ injection was dramatically effective. Many orthopedic surgeons experience dramatic improvement case in patients due to SIJ injections they perform themselves. When the cutoff point was 5, the specificity became higher, but we gave priority to sensitivity, and we chose score of 4 as the cutoff point. Nowadays, SIJ pain can be diagnosed all over Japan.
We have radicular tests for radicular problems, and we have for radicular, etc. This is very important.
That is. What is found in literature regarding pelvic belts is that they somehow appear to influence motion control and also that they appear to influence motion activation patterns. But an increase of motion in the sagittal axis, which is something that we found quite interesting as a result as well. 0.02% or less can actually cause alterations in pain perceptions for pelvic belt application, or maybe whether there are other mechanisms, again neuromuscular feedback loops, that might likewise also contribute to the effects, to the pain reducing effects of pelvic belt application that we could find in our clinical study.
As somebody who has fit the actual patients with braces, the pelvic brace that we've put on, I don't see a change. But when I take an SI belt that actually has pressure pads and I put it on a patient with SI pain, instantaneously they love it.
We're always talking about movement of the joint. Maybe it's not the movement at all. So maybe it's just ligamentous tension.
Yes, but there's another very important point in your question which relates to the extent of the movement and what we consider to be of importance for biological systems.
So, dear Thomas, dear Volker, thank you very much for inviting me and offering me a chance to give a couple of thoughts on a topic that initially seems to be a little bit outside of the realm of regular SI joint care, but if we're honest, it's quite in the center. A lot of patients are using opioids. But we have to be honest, there are a lot of people fall victim to opioids and opioid treatment, and usually the reason is a careless doctor who just doesn't really, assess how much to prescribe. So if these things come together, opioids, careless doctors, and problems in life, then usually things can happen. And when opioids are used for acute pain, the CDC says 3 days or less should be sufficient. So try not to go over 7 days. Good luck with this, but one has to keep in mind that these are the guidelines at the moment. So to sum up, how much is enough? Well, less than 50 MMEs per day and for less than 7 days. I think it doesn't have to be the surgical rate going up. It can also be the rate of NSAIDs and antidepressants going up in a better conservative pain treatment.
But when you say they maintain on those doses even though their pain are lower, how aggressive are you in saying no?
Okay, when patients really don't keep up with their lives and start being unfocused, unconcentrated, I talk to them aggressively about reducing opioids.
Certainly, I think there are other factors. I mean, I think patient expectations is big. I mean, in the United States, 10 years ago, pain was considered to be the fifth vital sign. So there was a lot of emphasis where we would measure people's pain and we would try to get them pain-free.
There are 3 questions about SIJ injections. The first, what is the best way to diagnose SIJ pain? The second, what is the best way to perform SIJ injection successfully? Finally, what's the best way to make a decision about SIJ surgery using SIJ injections? Depends on which way you choose, depends on each case and anatomical condition. You should perform SIJ injections yourself. Just after SIJ injections, you can evaluate the effectiveness and diagnose SIJ pain yourself with information just in front of you. If you ask other physicians to perform SIJ injections, you will get biased secondary information about the patient. I believe that the responsibility for correct diagnosis and the good result of surgery must lie with surgeons.
Just sliding down the sacrum and just resting on the ilium, and the contrast media just went right into the joint.
Today I'll be talking about whether the level of response to SI joint block really guides us in terms of determining who we should and shouldn't fuse. And finally, I think all of us would agree that we rely heavily on diagnostic injections, and we've already spent much of the afternoon talking about the importance of getting a good injection. However, if the patient does experience relief, even temporarily, then we're going to focus our treatments on the sacroiliac joint, and this would certainly include minimally invasive fusion. So what that means, if we followed the NAS guidelines, for instance, and used a threshold of 75%, you have 37.3% of patients who would not have received surgery. So again, that's a pretty high number of patients who ultimately did well after surgery, who otherwise wouldn't have been able to have surgery had we used the higher threshold.
Now, despite this large variation of techniques that are available, the clinical success of these procedures has been much more variable, especially when you compare radiofrequency ablation at the SI joint compared to other parts of the axial spine. So the reason we used a multi-tined electrode was because the posterior innervation we found was directly over the periosteum. So the multi-tined electrode gives you a nice wide lesion at the level of the periosteum in comparison to a conventional RF cannula, SI joint. In the vast majority, except for one specimen, at least 80% of the nerves were captured posteriorly. And if we compare this to the results that I had mentioned earlier in terms of the cooled RF technique, it seems that we're being a bit more successful in terms of capture rate with this technique. So our conclusions both from the Caddick-Varick study is that ultrasound needle placement using our previously described technique was consistent along the lateral crest, and the majority of the innervation to the posterior part of the SI joint would be captured with appropriate placement. And with the clinical study, we found that the diagnostic blocks under both imaging modalities produced similar results, and that pain, function, and quality of life improved 2 and 6 months after ultrasound-guided SI joint radiofrequency ablation.
Today I'm going to talk about a completely new method of treating sacroiliac joint pain. We start using local blocks with anesthetics. If they help, we consider diagnosis confirmed. How neurostimulation works, nobody knows. There is this fancy theory, the gateway theory, which postulates that to perceive pain, a specific gate should be opened. This is an 8-pole electrode, and we implant it between the foramina and the sacroiliac joint. And if the patient is not happy with the result, we can remove the complete system without affecting the bone or the joint. Before arthrodesis, or even before neurotomy, a sacroiliac joint stimulation test should be performed. Opioids.
You take people in that use opioids?
Yes. Yes.
And then
they reduce.
If they react very good to your treatment, they probably also will react very good to operation.
No, I don't know that. How do you know that?
Well, at least you proved that where the pain is coming from.
So, why you treat a patient where there is a fusion of the SI joint with a device of about 20,000 euro?
Well, first, I'm not. I mean, you have to show me what you mean, but I don't think that there was a fusion.
This is what I do. I don't wrestle with the patient. I mean, there's no thrusting. It's a relatively simple thing to do while the patient is standing, and I always do it when they're standing for this part. So osteoarthritis, here's incongruence, another example of that, and with the reaction in osteoarthritis, and this would be a good reason why an intra-articular SI injection would not respond, because pain's coming from some extra-articular or adjacent articular space. So that's, I think, the element. As you're looking at these cases, you have to have a broad mind about what you can and can't see on the imaging, and you have to have a broad mind about what you can safely accomplish by fixing the joint by various methods.
Since there are no data for SI joint fusion and osteoporosis, we have to talk about the fracture model. Most of the osteoporosis substances or anti-osteoporotic substances are tested for fracture models, and this is what we see in the next minutes. The authors of the study come to the conclusion that delaying bisphosphonate use for the first few months after the fracture might be wise, because the theory behind it is that the bisphosphonates go to the fracture site and will be accumulated in this region and so reduce bone healing.
The first, which I think is not really well thought out, and I think we'd all agree based on the talks that we've heard today, is that they suggest that imaging must show evidence of SIJ injury or degeneration, and this, I think most of us, based on these talks today, would agree is not correct. The next thing is the NAS requires at least a 75% reduction of pain. When is conservative therapy not enough? That's the converse side of this. So this is the new question: is when is performing surgery too early not recommended?
It also has to stick to certain rules that kind of like make the data cleaner and more reproducible. It has to have a clear protocol for a trial. It doesn't make much sense to really not have any type of design for conservative treatment. Again, pain medication patients are allowed to use opioids, allowed to use NSAIDs, are allowed to use nothing. So again, here we're not very strict. And what has to be discussed, of course, is the crossover, because this, of course, limits the true value and the long-term value of the conservative management cohort data over time, because they simply get lost into the surgical arm.
I think they're finished.
I agree.
Yeah.
So am I.
Thank you very much.
Okay, good morning, everyone. Thank you for coming so early, which is a deformity. So, in this situation, are we concerned with the deformity or its effects, and do we address it? Well, sometimes we do and sometimes we don't, because we can or can't. This is the only accurate anatomic illustration I've ever seen of this problem. The artery comes down, the nerve is beneath it. In this circumstance where there's no room for compromise and you add an osteophyte, you can have a serious problem. So even a subtle deformity can cause a problem here. So we have many reasons to have deformity of the sacroiliac joint and the traditional planes. It may not be easily visible in a simple gravity-based axial, sagittal, coronal. You might need to look at it in the plane of the joint. I showed angular changes. I showed collapse. I showed loss of structure, change in alignment and relationships. How is that not a deformity?
And we also know the subgroup that doesn't react on that, because the spur is on the ventral side and the nerve wants to be in the same place. So,
sure, I agree with everything you're saying. And this situation is, if you have an osteophyte and subluxation and capsular distension, if you can resolve the capsular distension and the subluxation and only left with the osteophyte, which you cannot address because it's anterior, it's inaccessible, they get better. You don't necessarily have to address all of the deformity. You address those elements that you can address. It's a fairly simple thing to do.
It's generally considered the leg symptom develop mainly from damaged nerve root. Lateral side pain grew to counter to lateral of knee, circled in death. SI joint disorder can be distinguished from damaged lumbar nerve root by knowing a characteristic feature like pain at PSIS or growing pain and entire lateral side.
So we all agree that pain over 6 is an issue, and it should be there for 6 months or conservative treatment done. But I need one reason that you tackle the SI joint and not anything else.
I'm glad to have an opportunity to share with you this presentation about sacroiliac joint pain after lumbar fusion. Does incidence of SIJ pain change according to the number of fused segments? If possible, one should extend fixation to the pelvis. In that case, SIJ pain may be hard to occur. I would like to conclude my presentation. Thank you for your kind attention.
Okay, so if we operate, we have to be prepared to fail, I guess, is what you say. If you have a broken arm and you don't put that broken arm in a cast, it's probably not going to heal. Same thing with the sacroiliac joint. If you don't provide stability, there's less chance of healing. Again, if you're looking for sources of failure, this can often be one. Compliance, again, were they jogging after the surgery? Were they putting too much weight and stress on their body after the surgery? To try to improve healing, improve bone quality before surgery, improve healing during and after surgery implants. Again, that pelvis is a 3-joint complex. So we have lots of options here that we can choose in our fixation. And then he said, you know, my SI joint pain is back, it hurts again. And this patient, unfortunately, eventually came back and we did the other side. And again, we went all out on the other side. But now she's 2 years out and is actually happy and has been back to full function. My personal method of treatment is to use the transfixation devices, but I always also put bone graft in my patients. So I limit weight bearing for 6 weeks. So 6 weeks using crutches and what we call touchdown weight bearing. So they can touch their foot on the ground, but no actual weight on that leg.
Again, this morning I'll be discussing the downside of obtaining a successful fusion of the SI joint. Does adjacent SIMEG degeneration exist, and is this something we need to worry about? So again, I think by fusing the SI joint, we wouldn't expect the same types of effects as we would when you fuse the mobile lumbosacral spine. So in conclusion, I think we would all agree that the incidence of SI joint dysfunction after lumbar fusion is fairly high. Obviously, additional biomechanical and clinical studies are needed to elucidate the pathomechanisms underlying adjacent SIMEG degeneration and quantify the risks to these adjacent structures, whether it's the lumbar spine, whether it's the hip, or the contralateral SI joint.
Do you think there is any possibility that we can fuse it in the wrong position, that could cause problem?
I think that's a very good question. I mean, I think there probably could be some motion, some degree of instability, but it's not the same that you're going to see for the spine or for the hip, for instance.
We talked about it yesterday. We have our patients with pain, and we have all these different methods to make a fusion, if you should do it. And we have the outcome measure results as well. And then we have the iFuse. So, and then the articles from the company is extremely high. It's 20 articles. This group, they said, you get a Ferrari, and you get this old car. But if you're not happy with the car after 6 months, you can get a Ferrari. We can say much about this data because it's made by the industry, but we can't ignore the fact that this data exists.
ladies and gentlemen, thank you for the invitation and the permission to speak to this really problematic issue in spine surgery. And the aim of this paper is really to show my now it's almost 30 years experience with doing SI fusions, and but I think it was a lot of steps what have to be done. But at the end, we had good results considering the outcome of fusion, number one, and number two, also at least the subjective assessment of the patient considering pain. It doesn't apply any distraction forces or compression forces, and it is not affecting in any way the maybe is re-enhancing the form closure system, but it's not affecting the force closure system.
Okay, and last question. Do you think this is the best way to do it?
It's a very easy way to do it.
No, the best way. If we are at the end of the line with SI joint implants.
I was thinking a lot about this because I think it would be very important to do this, for sure not in vivo, but maybe in a cadaver study, how the ligaments are become affected by the different
different methods.
I think this would be very important. It would for me, it's the next step to do it if I would be still at university.
Okay, thank you.
Reached SI joint, the culture SI joint, and bone graft, cancerous bone from iliac bone, and fixation with plate and 5 screws. Intuitively, this approach may allow the arthrodesis without detaching the iliac muscle. We change it to pararectal approach. And RDQ from 21.1 to 9.5 postoperative is improved. Number of arthrodesis is low compared to than in USA and Europe.
When you start a study, like in 2005, and you do a lot of work, and you finally got it published. But at that time, new techniques has come. So nobody really cares anymore. And case reports and case studies is pre-scientific. It's often retrospective, unclear inclusion criteria, and often made because of positive results. So there's bias there, and they often have no control group. This is the 12-month, and as you can see, 7 out of 8 had a positive effect.
These are preliminary results. We are still working on our data, but we have this is what we have figured out so far. And these are the clinical results taken out of the Swiss Spine registry. And this is in Swedish, I apologize for that, but they are much better, unchanged, and worse. But we couldn't achieve the same results with the Diana as other people have, unfortunately. I'm not sure why. Okay, what we would like to do is a randomized, double-blinded, surgically placebo study.
Completely straight and go within the recess, stay entirely within the bone and go to the superior dome of the acetabulum. So the distraction interference approach avoids these problems, and if you look at this slide, you have the implant, bone, and then you have nerve, artery, vein, and bowel. So don't miss. You're going to come in from the lateral side, don't miss, because the body's not waiting for you.
So I think this is a process, this is going on, this is a fusion process going on, and maybe we have to look for a longer time at our patients, how they are feeling. So I'm not good as John, but I think almost.
Yeah.
So I'd like to present the data from our institution using the Diana technique with 2-year follow-up, single surgeon, single center study. And even if there's a failed fusion, patients are generally not worse. There's no reports of patients starting off ambulatory and ending up in a wheelchair for the bone to fuse. adequately radiologically, so we didn't look before then, after the first few patients. And I'd like to show you one of these cases.
And he has done a lot of work on this, and he needs to be recognized and helping with this, not only the project, but this presentation. So you can see where it looks like with this model that rotates within the SI joint. And then we have the ability to add fixation using the alignment guide, which you can change the angles, but this is set to 45. And this is the end result.
Well, this is the sort of image tensile picture you can get. And you can see where you need to place your screw below this line within the body of S1. But I say this was my original plan, probably way too anterior, but then it broke completely out. And that's the sort of image we have to deal with. So I'm going to challenge anyone to see the sacrum is up there. Okay, just a sort of little a plug for Brit Spine. We're going to hold that in London in 2020.
Why do you think it's better for osteoporotic cases than iFuse, for example?
Time will tell, but I think it's a bigger, wider implant. I think the triangular construct resists rotation. Yeah, I think my concern is, well, as I say, you also get the bone grafting option.
Even I'm a heavy Diana user since years, but Michael asked me to step in this part because I've got a big experience, maybe the second biggest experience in the world with SI lock. So the first one was Miss Eden, but she didn't show up, so I've done two. So here you see one of the screws. So all implants have an HA-coated bone thread and are sterile packed. They have polyaxial washers to distribute the load, and you have an angle of 5 to 10 degrees. It works with navigation, which is the main point in our clinic. And it's a hard job to achieve a bony fusion with the implant, and it's good for more stabilization than the arthrodesis. It's more stabilization for me than an arthrodesis with the implant, and it's a good option in difficult SI cases if posterolateral approach is not possible or there's some additional problems.
But in the United States, it's probably not good enough. I mean, in this room, we have a lot of people who really understand the disease. People are supportive of these procedures. But if you go outside this room, you talk to other surgeons, if you talk to insurance companies in the United States, sometimes they don't see eye to eye. And when you share your own personal experiences, usually that's not going to be good enough. And these are also reflected in ODI scores as well, patient satisfaction scores. So again, I think it's pretty clear based on my own experiences and the data that we have is that iFuse does lead to significant improvements in clinical outcomes, certainly compared to non-surgical management. Now, obviously, one thing that's important for us, as well as surgeons who've never done the procedure, as well as patients and third-party payers, is the safety of these procedures. And obviously, one thing we focused on this morning would be the revision strategies, which Dr. Patel has certainly discussed already. So we're certainly not at the finish line, but I think this is a good start. And again, I think what separates iFuse from really any other system is just the wealth of clinical data there. That's a good question. I mean, I think when they're filling out like the VA scores and things like that, we have to be very specific about what we're talking about. And I think that's just in general, if someone's having, a bad day, they're depressed that day, that's going to affect something like their VAS score. So we're very, very specific about VAS for SI joint pain.
And I hope I still can learn you something. After these 2 days. I'm a paid consultant and paid clinical investigator by SI poster. I stick it on the wall next to my examination table to measure their range of motion. And then it's quite easy to read how many degrees they can reach. 75. Then I started to expand indications, and that's a topic of debate here. So what will happen if everybody starts doing this? And that's what I did. And we hardly ever see bone effusion. This is probably the only image you've ever seen after 22,000 operations worldwide of bone effusion. And if you get moderate results, most of the times they have other pain generators out there.
How are you on your worst nightmare day, beforehand, later? Well, what's your average after 2 weeks? I mean, how many pain pills did you take yesterday?
I know we're past time, so I'm going to keep it short. I don't have a lot of new information to add. And then we can make plans as to where those implants are going to be, and I can always say within the synovial part of the joint, even if the sacrum has an unusual anatomy, I can see where my implants will be, and I can keep the implants in place. After I drill, every time I drill, I get bone graft. So I have an autograft coming out with the drill every time. So my assistant collects that bone graft, and then I can make a small posterior inferior incision, and overall, I've been happy with the results.
So I'm certainly not exaggerating when stating that we all learned a lot during those 2 days. I would not only like to thank the presenters, but also the participants from 22 countries. Last but not least, I would like to encourage all participants to join SIMEG and thus support us with their annual member fee. And I would be even happier if you could actively help preparing the next Congress. It would be great if SIMEG managed to initiate research projects covering different countries. And I'm looking forward to meeting you again at the 3rd International Conference on Sacroiliac Joint Surgery. Thank you. And don't forget the video. Thank you.
Let's see.